Dr. Charoen Chuchottaworn, he is a senior consultant in Tuberculosis Division, Department of Disease Control, and former senior advisor from Central Chest Institute of Thailand. Dr. Charoen has many experience in caring TB patients, more than 30 years. He is being a principal investigator of many TB studies in Thailand. Today, he will talk about the challenges in detection and treatment of multidrug resistant TB. Please welcome Dr. Charoen.
Thank you very much, and I would like to thank the organizing committee for giving me an opportunity to be here. I don't have cases for you to make a vote, but I try to review the process that we use now in the clinical practice to detect the drug-resistant TB and also the multi-drug resistant TB treatment. We during the past few years, WHO launched out a lot of several guidelines and makes the clinicians confused with the treatment of the drug resistant. And yesterday I got another one from WHO also, and I will show you that one. Okay, so I would like to start with this slide that no laboratory result that we cannot make a diagnosis of drug-resistant TB. We cannot make a diagnosis of resistant TB from the clinical features of chest X-ray or the treatment history. So we need the result of the lab test. So laboratory test is a critical issue or crucial process that we need to qualify it and make it result correctly then. And we go back to the old definition, the diagnostic testing of TB that we use as a standard. We call it a standard conventional technique. That's published in 1969. That's 50 years ago. We still use it now, and we call it a standard. It's very old, and they use the definition of critical concentration and critical proportion to determine whether it's resistant or not. And actually, when you consider the critical concentration, that concentration did not correlate with the pharmacokinetics of the drugs in the blood. So that's confusing that is a good test or not. And because we use an indirect test, which means that we need a primary culture. It takes 1 or 2 months. The earliest is 3 weeks. And then we use a strain to do the sensitivity testing. So you can imagine that if you want to get the standard, the result of the standard conventional DST, it will take about 6 weeks up. With the liquid media, you can reduce that to 3 to 4 weeks. That's a long time for the patients. And you cannot change anything, the treatment, because you didn't get the result of the standard test. We call it standard test. So most of the researchers in the past 20 years, they try to find a new way to determine the resistance using a liquid media. So we get the BITEC 960, which is a liquid media base. And you can get the result in 3 to 4 weeks, not in a day or in a week, but 3 to 4 weeks. And this is a standard technique used in most of the developed countries, like in US or in the European country. But a lot of research try to look at the virus, the phage, or the. And now we come to the era of the molecular techniques. And with the molecular techniques, we can determine the mutation in the gene which related to the action of the drugs very, 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 very fast, just in hours or weeks, or days, not weeks. So, but the way to determine the single nucleotide polymorphism, we have a lots of technique, and like GeneXpert use now, and the RIPROB assay, that's very popular in determining the drug resistance. And the most advanced technique is gene sequencing, whole genome sequence or next generation sequencing. And very interesting, a lot of people try to develop the culture-based technique by using, instead of looking at the colony forming in the media, they're just looking at the color change of the media. So you can reduce the time to detect the growth of the bacteria. So you can determine the sensitivity testing by looking at the color. But anyway, this is a culture-based on liquid media. It still needs 3 to 4 weeks to get the result. But it's faster than the conventional technique of 3 to 2 to 3 months. And I personally, I like this MIC in the microtiter because as a clinician, if you get the MIC and if you know the pharmacokinetics of drugs, maybe in the resistant strain with the low-level resistance, you can adjust or modify the dose of the drug to cover the low-level resistance. If you don't have a drug to treat, you can play with the MIC and the pharmacokinetics or the dose of the drug. So in the future, maybe we will not using the conventional techniques. We go to the screening of the molecular, and then we use the MIC like this, or go to the sequencing, which will give more information. Not only the mutation in the gene related to the drug action, but also the transmission. For the whole genome sequence, you can trace the transmission of the strain from one patient to another patient. Like we have a data in Thailand that we can show the cluster of the MDR-TB spreading in one of the districts in Thailand. And that's a technique we use now. But the WHO approved the test of GeneXpert as a standard molecular test to diagnose TB. And also the loop-mediated isotomal amplification. The GeneXpert tests are based on the polymerase chain reaction, but the loop is an isotomal amplification. And this test, at the beginning, they call it a point of care test. Actually, I don't think that it's a point of care test. I call it near patient test, not the point of care. And any plex, which is used a lot in Thailand from Korea, this is a PCR-based technique also to detect the gene of DNA of the TB. For the drug substitute testing, WHO approved GeneXpert, live probe assay, but not this Aniplex and the whole genome sequence. I will show you. Oh, sorry. Okay. I compare the conventional technique and the molecular test, try to convince you that the molecular test is a good test, not the conventional one. And because of the standard, the conventional DST, this one we need a biosafety level 3 because we deal with the viable resistant strain. So we need a very safety lab, and we require expertise of the technician to do the test because we need to do the suspension, calibrate everything in the lab, in the BSL-3 lab. And we get the result in 2 or 3 months. But this is a standard in 2 or 3 months. And it's a standard test. Yes, it's cheap because you prepare the media and you prepare, it's like an in-house test. You prepare everything. So consider the cost is cheaper than the molecular technique. But, and also the benefit of this standard test is you can test all drugs that you have in hand, all drugs that you use to treat the patient. If you can get the powder, you can do the test. It's every new drug, if you can get the pure powder, you can do the substitute testing. So you can do the test. And because of the BSL-3 lab, only few labs in the country, like in Thailand, we have 3 or 4 labs that we can do the standard substitute testing, not in the peripheral or the small hospital like district hospital. But if you consider the molecular test, it's a near patient test. It's not a point of care test. Anyway, you have to send a specimen into the lab to do the test. But it's less, because it's a commercialized test, everything that the reagent calibrate already from the company. So less expertise from the clinician is needed. And you get the result in 1 day, theoretically. But actually in the routine practice, in the routine services, like in Thailand, we guarantee the result in 7 days, in a week. So it means that in a week you can diagnose drug-resistant TB. But it's a screening test. I will tell you later why we call it screening test. And it's more expensive because it's commercialized machines and the cartridge. So it's more expensive. Like a DSC in Thailand, the standard is it costs about $10 US, 10 to 15 US dollar. But this one, just 30 or 40 US dollar per test. And you can test only a few drugs. Like actually you test only the rifampicin. Yes, it's a core drugs that you need to test it. But as a clinician, so we we want to know what is not needed, but we want to know all the drugs that we use in the patient, whether it's susceptible or resistant or not. And high accessibility means that in Thailand, in the provincial hospital, maybe in the future, in the district hospital, they will have a machine to do this test. So this is a difference between the standard. And the benefit of a mammogram test is knowing the results just in one or 2 days. 1 to 2 days. And so we can change the treatment. And this is the figure of the test. And you can see that there's a booth outside this room. And it can detect only the rifampicin resistant. The definition of drug-resistant MDR is resistant to isoniazid and rifampicin. Why we test only the rifampicin? Because there's a limitation of the technique in the cartridge that we can detect only one gene. So we select the rifampicin gene because it's the most important drugs in the treatment of TB. Now, currently we use a new version of the Expert that we use, the Expert Ultra. And I compared the Expert 4G Generation 4 and the Ultra that we use now. The reason that they developed the new Ultra because the 4G Expert cartridge, that's limitation of sensitivity. So they improved the sensitivity of the test by using the new primer to detect the IX6110 and IX1081, which has many more than one copy, 1 to 25 copies in one mycobacteria. So it means that we increase the target to detect the DNA. So, and with this development, and we can reduce the threshold detection of the test down to 13 cells, 10 times high, more sensitive than the fourth generation. So if it's 13 cells per mil, that clinical implication is that if you have if you can get the good sputum specimen or the clinical specimen, if you had the Expert Ultra negatives, it's unlikely to culture positive or to be the TB in the patient. So because the threshold of 13 cells per mil is equivalent to culture, a little bit lower than the threshold of the culture. Because the culture we need about 10 to 100 cells per mil. So this is equivalent to culture. So that's a technique we use now that the Expert to diagnose. We can use it as a diagnostic tool and also to detect the resistance. Another technique that we use to diagnose the drug-resistant TB is a live probe assay. Live probe assay, you can see that we have a gene that we want to detect the mutation, and this is a MDR-TB hen test, and we have a rifampicin gene and CAT-G and HAG. So, and this is a control, and then you can see the M tuberculosis complex band here. So it means that you can use this technique as a screen tool for NTM. If you have a smear positive and you want to know whether this is an NTM or not, you can use this live probe and you can look at this band. If it's positive, it's MTB. If this band was negative, this is a non-tuberculous mycobacteria. This is the benefit of the LPA. And currently, we have two tests now. That one is a first line, and this is a second line. First line detect the isoniazid and rifampicin. Expert detect rifampicin only. Live probe assay detect rifampicin and isoniazid. And live probe assay, we have another test, second line, version 2, that we can detect the quinolones and also the amyloid glycoside here, the RS and EIS gene. And this is the technique they use. This is a mutate probe, and this is a wild type probe. I will not go into the detail of the test, but I just want to show you that in the insert packet of the live probe assay, they show that the sensitivity is about, for the smear positive is about 100% and specificity is 92. And also the smear negative, you can get a very high sensitivity and very high specificity. But when you look into the detail of the study, in the detail of the study, they use the strain that 68%. They use 100, I think it's about 156 strains to validate this sensitivity and specificity. And in 160, they had the 68% rifampicin resistant. So it means that the population they use in this study, they use a high proportion of rifampicin resistant. Again, in the same study, they show that the high test RPOS has a very high sensitivity and high specificity, both in the smear positive and smear negative. But 74% of the test strain resistant to isoniazid. Looks good. But in the real world, I show this slide because low positive predictive value in the new TB patient with a low risk of drug resistance. So it means that if you suspect the patient had carry the drug resistance, you test it, you get the result. Okay, if it's resistant, it's resistant because it's a high risk group. But if you use the test, the expert, in the general population, in every new TB patients, and if you had 2% of MDR in the new TB patients, you get the positive predictive out of 65. So it means that you have a false positive of 1/3. What does it mean? It means that the patient will treat with a drug resistant regimen, which is very toxic to the patient. And if you have a high prevalence of MDR or high risk group, you get a positive predictive value of 95%. So in Thailand, our recommendation is that if you look at the risk, if it's higher than 15%, the first test show positive, it means it's a true positive. It's a true. If the test show resistant, it means resistant. If lower than 50%, you need a second test to confirm whether it's resistant or not, because you have a very high false positive rate. I think this is important and a challenge to the clinicians that if you use a test, if you have to determine if it's resistant, if it's susceptible, it's not a problem. You can treat it as a susceptible with the normal regimen or the susceptible regimen like HRZE. But if it's resistant, you determine the risk. If the risk is higher, what is the percentage of resistance in the new HIV patient? My review shows that vary from 3%, 1 or 2% to 30% in the HIV-TB patients. In Thailand, we have 6%, 5 to 6% of new TB HIV patients carry the MDR. So in Thailand, if you use the expert to diagnose TB in the TB HIV patient, and if you get the result of a resistance to rifampicin, you have to do the second test before you start the MDR-TB treatment. Another point in the clinical practice is that the discrepancy between the standard, conventional, and molecular test. I try to summary to make it clear or more easier for the clinicians that if you have molecular test susceptible, conventional resistant, if you have molecular test susceptible, you start with the HRZE. And then you get the conventional test later that you is resistant. You have to change the treatment to resistant. Straightforward, because the molecular test did not include all genes related to the resistance. Like a rifampicin, 95% carry the resistance in the RPOB, but 5% we don't know. Maybe abnormal protein on other gene. So if the standard test shows resistance, it means that you have to treat as a resistant. Everybody understand this? And the point is that this one, if molecular test shows resistance, but standard test shows susceptible, what will you do? Treat as a resistant? Don't believe that it's a resistant? Treat as susceptible. My idea is that I believe in standard susceptibility testing, more evidence for this. So you have to change to susceptible. It's more confusing and makes we are not sure. Okay, molecular test is resistant. The reason is that the molecular test detect the mutation, but it did not tell that mutation changed which nucleotide to which nucleotides. You see? Just detect the mutation. And the point is that the nucleotide change, sometimes it doesn't change the MIC of the strain, or it's changed the MIC of the strain but not up to the level that determined as a resistant. Here, rifampicin RPOV, mutation at 0.5 to 6, you see, you have a range of resistance, high, medium, and low. If you change to L or N, means you have a susceptible strain. Even you can detect the mutation of RPOB. So it's like an expert or live process shows a mutation. This is a resistant from the molecular test. But phenotypic culture susceptibility testing shows that this is susceptible. Here you see the same mutation. You have a variation of the MIC. This is a cutoff. So this is a, and the most advanced technology now in UK they do the whole sequencing for every new TB patient. Thailand tried to do that, but we don't have the money. We are not so rich. We are rich. I cannot say that we are not so rich. Here, the whole genome sequence. This is my para study. I use the XCR strain, and you can see that from the whole genome sequence we can determine all drugs resistant by looking at the gene related to drug. Even the beta-quilin, the new drug, linezolid, beta-quilin, we can determine whether it's resistant or not. Clearly, we have nearly 100 strains that we had done this whole genome sequence. So I have only 2 minutes left. Yesterday, I got this a mail from my colleagues in the WHO, and molecular assay as an initial test for diagnosis of tuberculosis and rifampicin resistance. Yesterday, the WHO recommended to substitute the smear with the molecular test GeneXpert. This is the January 2010. Yesterday. So I show you, I will not go into detail. But in the guide, in this recommendation, lab recommendation, recommend to use the molecular test, substitute the smear. Professor Gyson, make a strange face. Yes, I got it yesterday. So I just put it early this morning. Okay, so, I will go to the treatment. This is all the guidelines launched out by the WHO in the past few years, in the 3 years. And I will go to, not into the much detail, I have only one minute left. First line, this recommendation, classification of the WHO in 2016. They classify as this. From before 2016, they recommend to use this one, this regimen, kanamycin, levodopa, erythromycin, cyclosporine. In 2010, a paper published in American Journal, Blue Journal, showed from Professor Bandun from Bangladesh, showed that this 9-month regimen with these drugs, you can get a success rate of 82% when doing study. The nickname of this regimen is Bangladesh regimen, so 82%. And also, we can get a very low side effect, only 21% compared to other regimen. And another study launched out in 2018, early 2018, from the nine West African country, and showed that also in a 1,000 MDR-TB patient, with the Bangladesh regimen, they can get a result of 81%. And in HIV also, they can get a very high success rate with this shorter regimen. And this shorter regimen recommended by the WHO in 2016. Here is the regimen. And the benefit of the regimen is that it's a shorter, 9 months only, and it's cheaper, low toxicity, and better compliance from the patients. And the contraindication for the shorter regimen is pregnancy and the extrapulmonary TB. And this is the first randomized control study of the MDR-TB regimen. Compare the longer regimen, the regimen 20 months regimen before the 2016, and the Bangladesh regimen 9 months regimen, published in the New England Journal 2019, early last year. And the success is comparable between the longer regimen, 20 months and 9 months. So this is the first RCT for the MDR-TB treatment. And So the regimen confirmed that the shorter regimen, Bangkok regimen, is an effective regimen to treat the MDR-TB situation. 2018, this paper published in Lancet 2018, and this is a correct 12,000 MDR-TB patients, and they try to collect the individual patient data and analyze. And WHO in 2018 used this paper, a publication, to reclassification of the anti-TB drug, a new anti-TB drug. And in this paper, they show that the HIV patient had a very high mortality rate after the treatment, 30%. And with the ARV, they can get a higher success rate in the MDR-TB treatment with the old longer regimen. So from this paper, the WHO recommend the new longer regimen. This is a new longer regimen. And then they reclassify the anti-TB, second line anti-TB drug. They reduce the importance of the kanamycin or aminoglycoside down to here. Down to here, you see. So from the IPD data, 12,000 patients, the benefit of aminoglycoside in the MDR-TB treatment was not very high. It's benefit, but not very important in the regimen. They can get the success rate not very high if we're using them. And faced with the toxicity of the aminoglycoside toxicity. And this is a recommended in 2019. Okay, I will go fast, I don't have more time. And here, for the HIV doctors, I would like to ask you to look at this paper, published in Respiratory Medicine 2018, Lancet. Here, 21% of the patients in South Africa were HIV positive. And look at the mortality rate. Patients receive BDQ and without BDQ. And with the BDQ in the MDR, you can reduce the mortality by half. And XDR patient treat with the second line drug, and if you use the BDQ, beta-querine, reduce the mortality by 60%. So it means that you have to use the BDQ in the MDR-TB patient with the HIV. My personal idea is that not only the HIV patient, but also in the non-HIV patients also. So here you see BDQ group here I will go first. And last month, WHO launched out this guideline. Key change to treat drug-resistant tuberculosis. They asked us to drop amikacin from the shorter regimen and substitute amikacin with the BDQ. Here. Fade out the aminoglycoside. So now the shorter regimen is like this, BDQ for 6 months and condition fed with the 5 drugs and here. One regimen that I think that it will be the future of the TB treatment, especially in the MDR-TB treatment or XDR-TB, is a NIX-TB. They use a BDQ, predominant linocyte, and they can get with the 3 drugs for 6 months, they can get the success rate of 80 or 88% to 90%. So just only 3 drugs for 6 months, you can get the result nearly 90%. So as compared to the previous or the history control, this is a very effective regimen, and you use just only 3 drugs, no injection at all. Okay. So my summary is that the rapid molecular test should be done in every new TB patient as a diagnosis, for diagnosis and as a universal DST. Low-risk patients, if the initial result show resistance, you have to reconfirm it. And TB HIV, if you have a low prevalence of MDR in the TB HIV patients, less than 15%, you have to retest it if the initial test show resistance. And low aminoglycoside in the drug-resistant TB is low. And not using it. Multi-drug resistant or drug-resistant TB, we should use the all-oral short regimen or new longer regimen as a first line drug. And BPAL or the next regimen is promising. It's a new promising regimen for drug-resistant TB because the 3 drugs that we use in the regimen can cover all resistant type, even the rifamycin, monorifamycin resistant. Thank you very much. Sorry, over time.
Yes. Thank you very much, Dr. Charoen, for your concise and very updated data on MDR-TB. So any question for the audience? Okay. Okay, we have one question over there.
Thanks for your excellent talk. I am from the Thai-Burma border, from the TB, one of the TB clinics for the migrants. My question is, one of my patients show with the GeneXpert positive for 2 times on 2 samples. But GACHA shows only the isoniazid resistant and BITEC resistant for the first line. But in the different lab, it shows INH and the rifampicin resistant. So what does this mean? Yes.
How to treat this patient? Is it the questions?
Yes, yes.
Yeah.
Now the discordant in the 2 different labs and also in the GeneXpert and the GACHA results, because in the GeneXpert shows are resistant for 2 times on different samples. But in the GACHA, rifampicin is not resistant. In one lot and another lot, rifampicin is resistant.
In this case, I think that you have to treat as a multidrug resistant MDR-TB, because
yes, sure.
if we cannot determine which is correct or not correct, because you have a culture that different two culture DST, the phenotypic DST, which show difference. So
Yes.
that's why I tell you that the expertise of the lab is very important for the standard assessment, because sometimes you make a dilution of the drugs in the media and something like that, and the error in the lab. So in the case that you cannot determine which one is correct, you have to determine the worst case situation. So in this case, you have to treat as MDR, because the MDR can treat the susceptible TB also. And you can use the shorter regimen, which is just three months longer than the 6-month regimen of the susceptible strains. Is it susceptible TB? Is it?
Thank you.